The neurobiology of addiction is a field that has really exploded over the last, let's say, 30 years. We are able to actually see what is going on in the brain in the addicted individual, the impact of the drugs that they are using on the brain, and then in some cases, the impact of some of the medications or pharmacotherapy that we use to treat their addiction. We can see improvement in brain function, which is very exciting. So as opposed to 50 years ago, when people thought that addiction was a problem of character or personality, or a criminal personality, or weakness of will, or other ways of looking at addiction, we really look at it as a neurobiological disease, or to put that in simple terms, a brain disease. We all agree that addiction is a chronic disease, that it has currently no cure, but excellent treatments, and that remission or recovery, which I use synonymously, are goals that can be met by many patients through a variety of different treatments, including pharmacotherapy treatments and non-pharmacotherapy treatments.
There's several different options available for people that are looking for medication-assisted treatment, and it really depends on the underlying condition that they're suffering from. If they have a problem with alcohol dependence, they may be looking at options like naltrexone or Antabuse. If they have a problem with opiate dependence, they may be looking again at naltrexone, but they also might be looking at methadone or Suboxone. The naltrexone is actually a blocker, and it both blocks the high people get from alcohol when they do that, and it actually also blocks the high people get from pain pills or heroin. Methadone is what's called a full agonist. You can look at the receptors in the brain as a door, and a full agonist opens the door completely into the brain, which allows the full activity of an opiate. And so methadone acts as a replacement therapy for opiates. So if someone's in withdrawal from heroin or pain pills, that's going to allow the full activity into the brain to replace that. But the problem with a full agonist is sometimes people can also have negative effects. There's risks of overdose. Buprenorphine, naloxone, or Suboxone is what's called a partial agonist, and that's like opening the door partway. And by opening the door partway, you're actually able to let enough in to help with withdrawal symptoms and cravings, but not so much where there's a risk of overdose or people look sedated or out of it.
Most of the evidence shows that if there is a pharmacotherapy which has been shown to be effective and to help with that addiction problem, that the use of that pharmacotherapy, in addition to the use of a variety of psychosocial treatments, such as one-on-one counseling or groups, or going to a mutual help group like AA or NA, that the combination of the psychosocial treatments along with the pharmacotherapy will usually provide better results than either one alone. I like to use the slogan that all treatments work for some people. No one treatment works for everyone.
Often people are reading online, so often they have an idea when they come into the office what medication is going to work best for them. And we have a discussion about it. What's right for them involves a lot of there's basic differences between these different options, and they would have to evaluate those differences on their own and then talk to a physician about these differences and kind of find the right fit for them.
One of the most common misconceptions and myths by both patients, but really more often significant others, and again the mutual help groups, is that when you take buprenorphine or you take methadone, you're just replacing one drug with another. And this is just not true, because we're usually replacing a short-acting opioid, which is generally causing damage to the patient's brain, with a long-acting opioid, which is meant to normalize and stabilize the brain. And we actually have data now to support the idea that methadone and or buprenorphine will improve brain function. It is very important for the patient and their significant others to understand that physical dependence does not necessarily equal addiction. Let's take a patient who's on insulin for diabetes. They must take their insulin every day. If they don't, they get sick. But nobody ever says that they're addicted to insulin. They just say they're on insulin, they have to take it every day.
If you develop opiate dependence when you're 20, there's a very good chance you're not going to live past 40. So I would say that's deadlier than diabetes. That's deadlier than thyroid disease. So plus the loss of functioning, even with thyroid problem, diabetes, people can often make it to work. They can often go to school. With people with active opiate dependence, they can't do those things. There's a complete loss of functioning.
It's easy to withdraw people over a week, but to maintain the abstinence from non-prescribed or illegal drugs, that's the challenge, and that's where these medications come into play.